Assalamualaikum and hi. Today we will be talking about autoimmune hemolytic anemia or AIHA. So one day, a patient came into the hospital and complained about his symptoms. The patient said, "Doctor, I feel very sick and tired. I cannot do most of my daily work. What is wrong with me, doctor?" The doctor then replied, "Calm down, sir. I will need to take some of your blood for some tests. Is that alright?" Then the bloods were brought to the lab. So the pathologist then said, "Aha, I know this patient have a condition called autoimmune hemolytic anemia. See, the antibodies are binding to his red blood cell and destroying them." The patient thinks that he needs to find more information on his condition, so he watched videos of lecture regarding AIHA. The lecture sounds like this. Autoimmune hemolytic anemia is a condition that develops when the body produces antibodies to destroy the present red blood cells. When the rate of red blood cell destroyed is much faster than the production of RBC, it produces this condition of not having enough red blood cell. There are several types of AIHA, which are warm AIHA, which antibody binds to the RBC at normal body temperature. Second, cold AIHA, which antibody binds to the RBC at 0 until 4 degrees Celsius. And the last one is mixed type AIHA, which have the presence of warm and cold antibody. There are also autoimmune hemolytic anemias, which include hemolytic transfusion reaction and hemolytic disease of fetus and newborn, and drug-induced immune hemolytic anemia.
Next, we move on to the etiology of autoimmune hemolytic anemia. For the main etiologic agents, for the warm autoantibodies type, the involved agents are immunoglobulin G or IgG, and for the cold autoantibodies type, the involved agents are immunoglobulin M or IgM. There is also mixed type, which is a combination of both warm and cold autoantibodies type, but the cases involving this type appear very rarely. Now we go to the etiology of the first type of autoimmune hemolytic anemia, which is warm antibody type. For the primary form of this type, the cause is idiopathic, which means that this condition arises spontaneously or for which the cause is unknown. This accounts for more than 60% of total cases worldwide. For the secondary form, which is basically derived from other underlying illnesses, the first cause may be from lymphoproliferative diseases. Lymphoproliferative disorders, LPDs, refer to a specific class of diagnoses comprising a group of several conditions in which lymphocytes are produced in excessive quantities. For example, chronic lymphocytic leukemia and lymphoma. Second is other autoimmune diseases such as systemic lupus erythematosus and rheumatoid arthritis. Third is non-lymphoid malignancies, and the last one is induction by drugs such as from drugs like alpha-methyl-dopa and penicillin. Drugs like alpha-methyl-dopa induce autoantibodies against intrinsic red cell constituents, in particular rhesus blood group antigens. The drug somehow alters the immunogenicity of native epitopes and thereby circumvents T cell tolerance. Drugs like penicillin act as haptens, inducing antibody response by binding covalently to red cell membrane proteins. Now we move on to the cold autoantibodies type, or also known as cold agglutinin disease. For the primary form, the cause is thought to be from low-grade proliferative disorders involving B lymphocytes with clonality of the cold agglutinin associated with monoclonal, in which means derived from a single clone of lymphocytes and having a single uniform epitope specificity. Next form of cold agglutinin disease is the secondary form. For the acute one, the cause arise is from infections such as infection from Mycoplasma pneumoniae or from viral infections such as infectious mononucleosis caused by Epstein-Barr virus. Cold agglutinin associated with viral infections are thought to be polyclonal, in which means derived from multiple independent lymphocytes and having multiple epitope specificities. For the secondary form of cold agglutinin disease, for the chronic one, the cause can be idiopathic, which means unknown cause, and also from B cells lymphoneoplasms such as lymphoplasmacytic lymphoma. The cold agglutinin associated with B cells lymphoneoplasms is thought to be monoclonal.
The next part would be lab findings. Coombs test is used to diagnose autoimmune hemolytic disease. So, what is the function of Coombs test? The Coombs test detects RH incompatibility between mother and fetus. There are two types of Coombs test, which are direct and indirect. The direct Coombs test detects maternal anti-D antibodies that have already bound to the fetal red blood cells, while the indirect test finds anti-D antibodies in the mother's serum. Next, we move to the process. The direct Coombs test is more common and checks for antibodies that are attached to the surface of red blood cells. In this test, the sensitization of red blood cells with incomplete antibodies takes place in vivo. The cell-bound antibodies can be detected by this test, in which antiserum against human immunoglobulin is used to agglutinate patients' red blood cells. The indirect test checks for unattached antibodies that are floating in the bloodstream. In this test, the sensitization of red blood cells with incomplete antibodies takes place in vitro. The patient's serum is mixed with normal red cells and antiserum to human immunoglobulin is added. Agglutination occurs if antibodies are present in the patient's serum.
The treatments for autoimmune hemolytic anemias depend on whether it is warm AIHA or cold AIHA. For warm AIHA, the first-line therapy given to patients is prednisone. It is effective in 70 to 85% of patients, given at an initial dose of 1 to 1.5 mg per kilogram per day for the first 3 weeks, until hemoglobin is stabilized at 10 gram per deciliter or more, and subsequently tapered off over the period of 6 to 12 months. Along with corticosteroid, patients are given supportive supplements including biphosphonate, vitamin D, calcium, and folic acid. The second-line therapy for warm AIHA is splenectomy. It is the removal of spleen. It is thought to be the most effective conventional second-line treatment to be proposed to patients unresponsive or intolerant to corticosteroids. Another second-line treatment with a proven short-term efficacy is rituximab, a monoclonal antibody directed against the CD20 antigen expressed on B cells. Other treatment options include immunosuppressant drugs such as azathioprine, cyclophosphamide, danazol, and intravenous immunoglobulins. As for cold AIHA, the treatment are protection from cold temperatures exposure, rituximab, transfusion support especially during winter, inline blood warmer, and immunosuppressant drug.
As a human, we have our own fitra. We love kindness, we love peaceness, we love happiness, and we have the thing called desire. Allah have guided us how to control our desire so that we will not go astray from the truth. These have the same concept as the antibodies in our body. They have the purpose to destroy the pathogens and the foreign entities in our body. But when the antibody no longer be controlled, chaos will be happen. So we need to reflect on ourselves. Do we follow the steps that Allah have told us to do in order to guide us to the truth, or we just let the desire and control? There is actually a learn process for us to learn from our body, and for us to praise the gratefulness of Allah in making our body system complete. I think that's all for our topic, autoimmune hemolytic anemia. That's all from us. Thank you.